most likely thing they'll do is get a periprosthetic fracture. So these will come more often. If you decide to repair them, this can happen. And then you're kind of stuck like this. Okay. So, I went way too fast. I have 15 more minutes to talk.
So, Ira, why are 40-year-olds getting total hips? What's causing that to happen?
You know, I wish I could tell you other than the fact it's just a natural progression of their arthritis. These guys, the two people, one was a rheumatoid, so of course they have problems earlier. And the other guy is just a normal guy who's got bad genetics and bad hips, got two bad hips. Usually those people get both. And they want to stay active and they can't walk anymore. So, but I probably do more total hips in people under 60 than over 60 today. And it's kind of the way things are going. Any other questions?
I have one.
Come on.
All right, so when we have,
Excuse me, I have to change the x-ray, or the picture.
when we have a hip pinning, we don't need to use a wedge, but with the bipolar, we do it. And is there a reason, except just to stabilize the hip?
Yeah, when you put a prosthesis in, there's a chance you get a dislocation. When you pin someone's hip, their hip capsule, their whole hip has not been disturbed. The joint has not been disturbed at all. It's all below the joint, and when the joint is not disturbed, they can't dislocate their hip. They might rotate their leg and bother and have pain, but they can't dislocate. And the wedges, most of us are using the wedges on hip pinnings, correction, on bipolars, prostheses, because they're older and they don't pay attention. In the more normal person that has a total hip, the wedge is not always necessary. At least for me, I'm not sure what my partners are doing with the wedges.
At what age do women have trouble with bone density and fractures?
It actually starts early. I mean, there's not anybody in this room that shouldn't be taking calcium. That's male and female, by the way. They found more osteoporosis in men than ever before, so men should be taking calcium the same as women. Just you should be taking more. But you start to see it in the 50s more commonly, and sometimes in some unlucky women in their 40s. Again, it depends upon your size. It depends upon your heritage. And so, but hip fractures are obviously far more common in women. Yes?
How important is it when people come back from the OR with non-weight bearing or toe touch weight bearing, how important is it that they maintain that, or if they don't,
What happens?
Yeah.
It's a good question, and a lot depends upon the nature of the fracture. The femoral neck fracture with the 3 screws in it, those are not that stable. They're not very tolerant of a lot of weight bearing. The complex fracture that I showed with the long nails in them, we put those partial weight bearing because we don't trust the fracture, but that's probably a much more stable construct. If they put a little more weight on it, those are probably much less problem. And then, of course, the prostheses, assuming you don't have a problem, you can bear full weight on a prosthesis, right? Oh, I did that? Stop that. And you can bear full weight on a prosthesis. In the old days, people thought you shouldn't bear weight on those prostheses right away, but not anymore. And we seldom use cement with the prostheses, so weight bearing is good. God, what am I doing? What am I doing?
Why the less you use of cement these days?
Why? Because cement probably causes more trouble than it helps. The only time I personally use cement is if I were doing a bipolar prosthesis and I just couldn't get the stem to fit right, I'd use cement. But I haven't used cement in a femur in how long you been here, Barry?
I think I've done it maybe twice.
In 10 years.
10 years.
Yeah.
Yeah.
So it's very uncommon to use cement anymore. Sometimes there'll be an older lady who has a great big femur. You know, as you get older, what happens is your femoral canal, as you become osteoporotic, gets larger and larger. The bone, the cortical bone here, this is cortical bone. Cortical bone disappears and your femur gets bigger. When that happens, every now and then you can't get as stable a construct, so people will use cement, but not in the so we don't put sockets in often, but you don't use them in the sockets ever. There's no reason to. Yes.
I have a cousin who has, had both knees replaced, a couple years younger than me. She has severe allergies, and they have told her after about a month or so after she's had the surgery, she's starting having a reaction to it. And they say that she seems to be reacting to how the prostheses are prepared, not really sterilized. Have you heard of anyone having reactions to this?
No.
It happened down in Salem, name dropping, that's where she's had it done both times. Not that they've had to take anything out, but
Never heard of it.
had some weird.
Never heard of it. Some of the things that are certainly in the news are, reactions to metal on metal kinds of things, but not in total knees. And I don't think I've ever heard, read, or ever heard of an allergic reaction to this kind of stuff.
Can you talk about that metal on metal reaction that they've been talking about?
Yeah. Well, this is in total hips, and we were all enamored, including myself, were enamored with the fact that you could do a total hip on somebody and put a prosthesis in that would probably last as long as they would, almost no matter what age they are. And it was a metal ball in a metal socket. And the wear rate of metal on metal is extremely low. And the fact you could use a great big ball would mean that they'd have better range of motion, less chance for dislocation. But what has happened is in a number of people there has been metal particulate matter that gets out, and we all knew that it got into your bloodstream. I mean, if you have any total joint, there's a chance that you have higher cobalt and chromium ions in your bloodstream than anybody else. Now, apparently we all have some chromium in us from stuff that you eat that's there, but cobalt is uncommon. And the question always was, does that cause problems or doesn't it cause troubles? And most studies have said it does not cause any long-term trouble. But what happened with a lot of these metal-on-metal prostheses that wore badly or wore quickly is that you got a local reaction to the metal ions, creating big cystic fluid-filled masses that were painful and causing big problems. I have a lady that I revised for that problem, and she looked like when she walked in the door, she had an extra saddlebag on her leg because it was about this big fluid-filled cyst of metal debris. So metal-on-metal hips are pretty much out. People that are doing them, I think, are taking a big chance because most people think they're bad. So and we don't know exactly, because some people have them and they're fine, and some people have them and they're certainly not fine.
What about minimally invasive? Were you doing those for a while, or what
No,
exactly is that?
minimally invasive. It's both hips and knees actually, but it's a great marketing tool. It makes you sound like you do something that other people can't do. And I always have a great story that I attach to that, because I once went to Salt Lake City for the day to do total hips with this guy who does 500 total hips a year. So I spent the day with him because at our meeting he showed this new way that he was doing total hips that was much less invasive, and it looked like something for me that I could adapt to what I was already doing. So I went over there and spent the day, and the first case started, and he started doing the surgery, and I said, hey, Kim, it looks like you're doing the surgery like normal. That's the way I do it. And he said, oh yeah. I said, I don't do that anymore. It's way too much trouble. And so and I said, well, did you ever do, the Zimmer Corporation came out, I'll badmouth them for a minute. The Zimmer Corporation came out with a technique to do total hips that they called minimally invasive surgery. And they developed a technique with some orthopedic surgeons that was small, couple small incisions and a way to do a total hip that was totally different, and the complication rate went up tenfold, and it was very tough. And one of the problems is that they marketed it to the public pretty quickly, so people would come into you and say, do you do minimally invasive surgery? They still do, but very far less. And so if there are 300,000 total hips done in the United States a year, the statistics are that 75% of them are done by people that do 12 or less a year. So these are smaller town people who they probably do a good job of a regular total hip, but their patients were coming in and say, do you do minimally invasive hips? Well, guess what? They had to learn how to do minimally invasive hips so they could do what everybody else is doing. Well, the complication rate went through the roof. Well, when I was in Salt Lake City, I had done 2 minimally invasive hips. One was a smashing success and one was an abject disaster. I mean, that lady by the time we finished, she had 4 surgeries. She's fine today, but believe me, it was a nightmare. Actually, one of the x-rays almost looked exactly like this. So I said, he asked me if I had done minimally invasive surgery. I said, yeah, I did 2 of them. And I said, how about you? How many did you do? And he said, well, I did 4. He said, I guess you're twice as smart as I am. So it's a technique that pretty much has fallen by the wayside. There are some people in town that advertise they do minimally invasive surgery, and they do not. But that's how they get their patients there. There's a lot of direct-to-consumer marketing that I actually despise. I mean, I don't think the consumer should come in with an idea of what they want done. I think it's interesting that people know a lot more today, but I think that, I had a lady recently that went to someone else because she told me in a letter, she said she knew an anterior hip was the best way for her. Well, she's had nothing but trouble with it. I know that from some other people, but it's not the results of hip replacement or knee replacement or anything else are not technique related. That has been proven over and over and over and over again. At 1 year, it doesn't matter if you had a minimally invasive or a maximally invasive, and believe me, everybody's seen a total hip. There's nothing minimally invasive about a total hip or a total knee. You got a hammer, you got a drill, you got a saw, you're pounding, it's not minimally invasive. You might make a smaller incision, but it's not minimally invasive. But the results are all the same at 1 year, so it doesn't matter how you do it.
What are your thoughts on navigation systems or robots?
Navigation is really falling out of favor. Yeah, people aren't navigating hips or knees much anymore, and the hip navigation never worked worth beans. So that's a problem. Robotic stuff right now is relegated to partial knee replacements. They do have some robotic hip stuff that's out. Again, I think it's a great marketing deal because one of the things about the Mako knee that they're using, the knee itself has no track record. No one has any idea if it's a good knee or a bad knee. No one has any idea because they make it and they never made it before, but it goes with their system. What I think will supplant the robotic stuff, because Mako, their business is not doing well. I don't think they're going to stay alive much longer unless somebody buys them. But what's going to take over are the signature/shape match, which is a deal where people who have a total knee get a They get an MRI scan ahead of time, and custom guides are made for their particular knee. It's custom made for their knee. And that's both in the partial knee and the total knee. They haven't done it for hips, but they're working on it. I hear it's going to be out not too long. So that probably will take over the robotic stuff, because the robotic stuff is not a slam dunk. Again, it sounds great.
Could you touch a little bit on weight? We deal with large people, you know, with degenerative hip disease, in the high 400s to 500 pounds. What type of weight?
Well, 400 or 500 pounds is out of anybody's range. I mean, I think if you're not significantly below 300, you probably shouldn't be doing it. And what is significantly below? Someone called the other day office and asked about that very same thing. And I've done people that are 280. I'm not sure it's a good idea. It's not just that they're hard to take care of in the first place, but their complication rate is enormous and enormously higher. And when they get complications, it's almost untreatable. So, but I think significantly under 300 is the way to go. But 400, I don't know anybody that's doing people that big. And I hurt my back the other day on someone that weighs about 250, so.
What do you do with those patients that are 200 pounds and break their hip?
And break their hip? Oh, you got to fix those. There's nothing you can do about that. I mean, Dr. Lamprecht did a lady at Providence who's barely 5 feet tall and weighs about 450. See, that's 90 pounds a foot. So, and he did a hip pinning on her. He put screws in it. And, you know, that's this much to go through before you get to the bone. So. Any other questions? Good questions, bad questions? Appreciate everybody getting up early. Thank you.